So for the agenda of my talk, I'm going to go over the rationale for hypofractionation for prostate cancer. We'll discuss the prospective and the randomized trials. I'll review stereotactic radiotherapy and compare it to HDR brachytherapy. We'll go over a retrospective series and quality of life series and discuss ASTRO NCCN guidelines and randomized trials. So we know from a number of randomized trials and retrospective series that as we increase the dose of radiation therapy externally, we improve biochemical control rates. That comes with a little bit of a cost in the increase in long-term normal tissue toxicity, and that's limited with better treatment delivery, so the evolution from 3D conformal to intensity modulated and targeting IMRT to IGRT. And on a conceptualized model, if you look at sort of graph out different series which have tracked doses of radiation that have used with different fractionations, on the x-axis you have the equivalent total dose and the y biochemical control. It assumes somewhat of a sigmoidal shaped curve, which is somewhat morphologically similar to cell survival curves that are dictated by what's known as the linear quadratic model. So as you increase dose, you increase biochemical control rates, and eventually in the sigmoidal type of curve, if you keep increasing the dose, the control rates plateau. And historically, the way that one increases dosing with external radiation is to increase the number of low-dose fractions. It widens the therapeutic index, which we'll get into, based on parameters of sensitivity to radiation known as alpha and beta. And so I apologize, we're going to have to go through the radiobiologic rationale, but I'll do it very quickly. In general, radiation biologists approach alpha-beta ratios in a binary fashion to describe high alpha-beta tissues and low alpha-beta tissues. High alpha-beta tissues have little sensitivity to the dose per fraction employed. That's similar to most tumors in early responding normal tissues. Low alpha-beta ratio tissues have a greater sensitivity to the dose per fraction employed. That's emblematic of late responding tissues. So for prostate cancer, the rectal mucosa and bladder. And so the concept of fractionation is to exploit the difference in sensitivity between tumor cells and the late responding normal mucosa. And so the rationale has always been, since most tumors are not sensitive to fraction size, whereas normal tissues are, you simply increase the dose in lower fraction numbers. Prostate cancer cells have somewhat of a different biology from most epithelial tumors. They have a lower alpha-beta ratio. Folks disagree on what the precise number is, which we'll go into, but it does portend for a higher degree of sensitivity to dose per fraction employed, and one can harness the advantage of prostate cancer's unique radiobiology by delivering fewer fractions with a larger dose. And so this is just an example, and again, it's given some of the assumptions that prostate cancer has an alpha-beta ratio of 1.5 and rectal mucosa perhaps alpha-beta ratio of 3. But if you compare 81 gray over 9 weeks with 7 gray times 5 fractions, you could see even though the physical dose 81 versus 35 gray is much lower with a stereotactic approach, you're actually giving a higher normalized dose to the prostate cancer with a fewer fraction approach and a lower dose to normal tissue. And the question of whether or not the alpha-beta ratio of prostate is in fact set in stone is one clearly that's not the case. There are a number of radiation biologists who are very prominent in our field who have cited different alpha-beta ratios, but most of them gravitate to a lower one than the normal mucosa surrounding the prostate. And in fact, this is a review article by Alan Katz, who has looked at different fractionation schemes that have been employed, all with outstanding biochemical control rates, and said, and I think this is an interesting slide, if the alpha-beta ratio of prostate cancer truly was much higher, you would have vastly inferior doses employed, and it wouldn't make sense, the biochemical control rates that have been seen, whereas with a lower alpha-beta ratio, it seems to sort of bear out based on retrospective series. The concept of hypofractionation and SBRT is not novel in the world of radiation oncology. Hypofractionation for radiation is considered standard of care for early stage breast cancer, for melanoma. Stereotactic radiotherapy is considered standard of care for inoperable non-small cell lung cancer, CNS malignancy, oligometastatic disease, pancreatic cancer, etc. The benefits to a shorter course of radiation include better access to care, improved patient compliance, it's more cost effective, you have a higher what's called biologic effective dose or normalized dose of radiotherapy, and the phase 3 data is either mature or maturing depending on which or the extreme of hypofractionation employed. The downside is clearly an increased reliance on the sophistication of the treatment planning equipment and your physicists, as well as the machines, and the long-term toxicity continues to evolve. Regarding the prospective trials of hypofractionation, this is a review by Bridget Kuntz over at Duke, demonstrating a number of series with excellent long-term outcomes, showing that hypofractionated radiotherapy has been well tolerated with excellent biochemical control. And again, when you graph out conventional and hypofractionated regimens and graph it on the x-axis BED versus y-axis biochemical control, again, it assumes somewhat of that morphologic similarity in the sigmoidal shape. So hypofractionation clearly is able to generate higher doses with sustained biochemical control and low long-term side effects. There are a number of randomized trials that have been recently published and presented on hypofractionation. This is the RTOG trial, so 0415, which randomized gentlemen with low-risk prostate cancer between conventional fractionation versus a modest hypofractionation. In the design of this study, it's important to bear out that if the alpha-beta ratio of prostate cancer is more similar to 10, a higher number, essentially the doses employed would be isoeffective. And if the alpha-beta ratio of prostate cancer is lower, then the hypofractionated arm should in fact do better. And with a median follow-up of 5.8 years, the 5-year disease-free survival and biochemical recurrence rates favored the hypofractionation arm. The late GU toxicity trended in favor of conventional over hypofractionation. The late GI toxicity was a little bit higher, but again, the devil's in the details. Most of that toxicity was driven by grade 2. The PROPHET trial over at Princess Margaret Hospital took patients who had intermediate prostate cancer, mostly, some with low risk, some with high risk based on PSA, and randomized them to conventional fractionation versus a 4-week course of hypofractionation. And at 5-year follow-up, there was no difference in biochemical control rates. There was no difference in long-term toxicity, GU or GI. The trend actually does favor the hypofractionated arm for this cohort. Interestingly, the acute GI toxicity was higher for the hypofractionated arm, whereas the late GI toxicity was lower for the hypofractionated arm from this group. And so their conclusion at Astro was based on the convenience and cost and the efficacy demonstrated, hypofractionation should be considered a new standard of care for patients with intermediate risk disease. The CHIP trial from the UK randomized patients with 3 dose levels. These are patients who had mostly intermediate, some high-risk disease. It was a standard arm, the same one that the PROPHET trial used, the 4-week course of radiotherapy, and then they knocked a fraction off. And at 5-year follow-up, there was non-inferiority of a hypofractionated regimen. The 4-week group seemed to do the best, but again, non-inferiority was demonstrated. There was no difference in late grade 2 rectal or bladder toxicity. And the conclusions from these authors, once again, was that this should be considered a new standard of care for patients who have intermediate risk disease. If you track out the Royal Marsden experience and sort of their patient composition who receive external beam radiotherapy, over years, the 4-week course has become the most predominant form demonstrated. We'll now go to SBRT. So it is not lost on me in an era where the amount of brachytherapy, folks are lamenting the decline in sort of the overall utility, and I work at a center that does quite a bit of stereotactic radiation, that in fact I may be the zebra in this photograph. In terms of the historical trends, so I was a history major in college, and I think it's interesting to graph out how history different trends over time. And so one of the studies that we conducted is we analyzed 20,000 accepted abstracts over at Astro in oral and sort of written form or poster presentations over a 15-year course of time. And the point of this study was really to try to tease out whether or not or quantify there are different eras in the form of radiation therapy. And you could see there are inflection points. In the year 2003, the most common modality that was accepted into Astro was IMRT compared to brachytherapy. And in 2011, there was once again an inflection point, really suggesting what we sort of see in clinical practice, at least in the States. It's heralding in this era of stereotactic radiotherapy. And if you break it out by disease site, you could see the inflection point. This is around the time that Bob Timmerman published in JAMA the RTOG non-small cell lung cancer results. So for lung cancer, SBRT became the most common. With GI malignancy in the late 2000s, it became the most common. And in 2014, there was an inflection point at Astra for prostate cancer. And so SBRT is known as ultra or extreme hypofractionation. And clearly on a diffusion of technology scale, brachytherapy sort of evolves first. You have the IMRT, IGRT, the hypofractionation, and SBRT that I mentioned. But I would argue, according to a natural kinship, SBRT is much more similar to brachytherapy, at least HDR, in terms of the doses that are employed and the philosophy behind it than IMRT. And if you look at sort of ABS guidelines or any society's guidelines on doses that could be employed for high-dose rate brachytherapy and compare it to common doses employed with SBRT, they're quite similar. And if you look at dose distributions, again, and these are cherry-picked photographs, it's sometimes difficult to tease out what an HDR brachy plan would look like compared to SBRT. Similar to HDR brachytherapy, SBRT employs rapid dose fall-off. You're capable of delivering a heterogeneous treatment plan. It's cost-effective relative to IMRT, and compared to LDR, similar to HDR, it's more forgiving to larger prostate sizes, patients who have higher baseline IPSS or AUA scores, history of Terp. And I think an important concept which has been articulated quite often by Dr. Collins at Georgetown, it seems to be easier to teach to residents. Brachytherapy is so operator dependent. The doses are not new again, so if you look at the Alvaro Martinez studies and a lot of the HDR brachytherapy long-term outcome studies, these are doses that have been historically employed with excellent long-term results. This is a series over in Japan comparing patients long-term who had intermediate and high-risk disease with different forms of HDR brachytherapy, demonstrating excellent biochemical control. This is out of UCLA, also similar doses demonstrating excellent long-term biochemical outcomes with doses now that are employed with stereotactic radiation. This is out of our center looking at median PSA over time. So at NYU Winthrop, our PSA naders are 5 years are around 0.2, pretty similar to the Georgetown experience that's been published. This was out of Dr. Roach's group at UCSF, which compared patients who received conventional fractionation to those who received stereotactic, showing that patients with stereotactic radiotherapy had lower PSA naders. They had a greater rate of decline in PSA 2 and 3 years after treatment, all consistent with a higher BED. They combined their data set with UCLA and looked at patient PSA responses. IMRT is in blue, SBRT is in red, and HDR is in green. And again, you could see over time the SBRT group had lower PSA nadir, very similar to HDR, and was higher than IMRT, whereas IMRT plateaued at about 2 years post-therapy. Both HDR and SBRT continued to decline. This was a multi-institutional cohort series that compared outcomes in PSA control at 5 years between SBRT and high-dose rate brachytherapy, demonstrating equivalence or non-inferiority of SBRT with HDR. I asked one of the authors about this in person, and they sort of lamented the fact that the SBRT looks to be a little bit worse, although not significant statistically. He indicated they had a higher unfavorable risk composition. In terms of retrospective series, the one that really carried the day and dictated a lot of the interest was Chris King publishing in the Red Journal several years ago their long-term outcomes of stereotactic radiotherapy. And since then, the number of institutions reporting their outcome that continues to evolve, some now with long-term data. This is already sort of out of date. This list continues to grow, but many centers are now reporting it. This is a pooled analysis of 1,100 patients across a multi-institutional consortium who were treated with SBRT for prostate malignancy, showing at 5 years excellent low, intermediate, and high-risk disease control. This particular consortium did not find a difference in outcomes whether or not patients receive androgen deprivation or dose escalation. These, again, are carefully selected patients. Bob Meyer over at Swedish Cancer Institute presented at Astro a slightly dose-escalated version of this, of giving a larger dose to the actual prostate gland, demonstrating at 5 years outstanding biochemical control rates, which again, if you graph out according to historical IMRT dose escalation, they're favorable. For intermediate risk patients, also outstanding biochemical control at 5 years. And again, if you compare it, and I know it's not exactly kosher to do so, with Ascend or the Sloan-Kettering dose escalation, they seem somewhat comparable, and the late toxicity was rather modest for the SBRT group. These are the 9-year outcomes from our institution by Alan Katz that have been presented, again demonstrating excellent 9-year biochemical control rates for patients with low and intermediate risk disease. He personally did not see a difference in biochemical control based on dose, but again, this continues to evolve. This is a series at 10 years for low risk disease, demonstrating again sustained biochemical control rates with SBRT. Dr. Zalewski at Sloan Kettering presented last year at ASTRO his dose escalation study with stereotactic radiotherapy, showing that with modest follow-up, patients with SBRT in his cohort had excellent median PSA naders, had very low risk of grade 2 rectal bleeding, low risk of GU toxicity as well. He had one stricture that he noted. And this was sobering data that was presented, and I think it's thought-provoking. Despite patients have extremely low PSA naders and failure 2 years post-treatment, he biopsied as many of the patients who would agree and found a non-trivial rate of post-radiotherapy positive biopsies, even in some of the dose-escalated arm. There are a lot of questions that this obviously brings up. We know in the field of radiation that we don't want to, that the prostate cancer malignant cells can still respond to radiation with increased time. So perhaps some of these patients would have converted negative to 3 years. Again, if you look at the UCLA, the UCSF, and a lot of the other PSA nadir data sets, it shows that the nadir continues to decline past 2 years. The question of what a clinical significance is of a low PSA with a positive biopsy remains. How these findings compare with external radiation therapy is also a question, and also the platform that's utilized. Some forms of platforms prescribing to lower isos lines may be delivering higher doses. Something to me that's interesting is if you look at this data, it reminds me very much of what Dr. Stock and Stone looked at 14 years ago in the Red Journal, which is not surprising. As you increase the dose that's employed, you decrease the positive biopsy rates. And some of this literature might be quite interesting to compare to try to derive a true alpha-beta ratio. In terms of quality of life series, this was an article by James Yu that was published in the JCO, where he looked at Medicare claims data and showed that SBRT was more cost-effective than IMRT, but it had more GU toxicity. Again, the data, the devil's in the details. There's no real mention here of the doses that were employed or the techniques employed. This is a review by Bob Meyer looking at SBRT use that's been published with now long-term outcome and comparing it to the external beam dose escalation series and brachytherapy series, showing a very favorable and comparable long-term grade 2 and 3 rectal and GU toxicity. This is an interesting study, which is also a multi-institutional comparison of patient-reported quality of life parameters. So 800 patients filled out 1,200 EPIC forms, and they were followed. These are patients who had IMRT, SBRT, and brachytherapy. SBRT is in red, green is brachytherapy, blue is IMRT. In terms of irritative urinary toxicity, like obstruction or incontinence, SBRT compared favorably with brachytherapy. In terms of those who had bowel toxicity, also SBRT compares favorably on EPIC forms. I would take with a grain of salt the sexual function, which shows an improvement with SBRT also. I think even taking into account some of the multivariate analysis, I think these patients had lower use of ADT. On Markov models, again, nothing really compares with brachytherapy in terms of cost-effective medicine, but SBRT clearly is more cost-effective than IMRT or with proton therapy, certainly. Both ASTRO and NCCN consider hypofractionation to be a standard of care now for men who have prostate malignancy, and SBRT is considered a cautious alternative in centers that perform a large number of these techniques. This is a randomized phase 2 trial by the RTOG comparing, again, similar, not exactly the same as the PROPHET and the CHIP trial with hypofractionation for patients with low-risk disease and randomized to an SBRT dose that is also modest. There are a number of international randomized trials now that are being conducted, and they are accruing patients with SBRT. I think, in my opinion, one of the more interesting ones is from the Royal Marsden, Nick Van Os, the PACE trial, comparing patients who have low intermediate risk disease between prostatectomy, SBRT, and conventionally fractionated radiotherapy. And clearly, this data is going to be instrumental in helping us explore and tease out the difference in outcomes, both biochemical, quality of life, and the maximum tolerated doses. In conclusion, prostate cancer has a unique biology that appears to favor higher doses per fraction with external radiotherapy. There is mature data regarding hypofractionation for prostate cancer. It's considered a standard of care. SBRT, and you could choose your adjective, is an alternative. So it's either a cautious or validated, depending who you are. It should be performed at high-volume centers with expertise, as promising early results, and clearly the long-term data is limited and continues to evolve. There are mixed quality of life parameters that have to also be explored with greater follow-up. Thank you so much for your time.